Hello, this is a video lesson on procedures of the pelvis and the hip. So we're going to talk about room prep, patient prep. As far as that's concerned, we want to make sure everything's ready for the patient to come in, have everything ready for the patient preparation is to ensure that the patient's in a gown. Clinical paperwork and history, having it all prepared. Proper radiation protection is not going to be shielding, it's going to be proper collimation. The table bucky, if portable, we will need a grid. We're going to use 40-inch SID for all images of the hip and the pelvis, and respiration to suspend for all images. For the AP projection of the pelvis, the patient is supine. We're going to center the mid-sagittal plane of the body to the midline of the image receptor. We're going to check the ASIS to tabletop distance on each side to ensure the pelvis is not rotated. We want the heels separated 8 to 10 inches. Unless contraindicated because of trauma or pathologic factors, immediately rotate the feet and the lower limbs approximately 10 to 15 degrees to place the femoral next parallel with the plane of the image receptor. We want to center the image receptor at the level of soft tissue depression, just below the palpable prominence of the greater trochanter, which is midway between the acis and the pubic symphysis. In average-sized patients, center of the image receptor is approximately 2 inches inferior to the acis and 2 inches superior to the pubic symphysis. If the pelvis is deep, palpate for the iliac crest. Adjust the position of the image receptor so its upper border projects 1 to 1.5 inches above the crest. So our central ray is going to be perpendicular to the midpoint of the image receptor, and adjust our collimation to 14 by 17. If you have a smaller patient, you can collimate 1 inch beyond the skin shadow on the sides. So we should have an AP projection of the pelvis and the neck. Pelvis and the head, the neck, the trochanters, and the proximal 1/3 or 1/4 of the shaft of the femora. The 15 to 20 degree rotation, internal rotation, is going to reduce that foreshortening of the femoral necks by placing them parallel to the image receptor. In this image, we're taking a look at the improper positioning up here at the top with the proper positioning in the bottom image. In the top image, we can see that the lesser trochanters are in profile. That's not something we want. Plus, the femoral necks are foreshortened. In the lower image, we're able to see we've taken care of that foreshortening of the femoral necks. We don't see that, and we also barely see the lesser trochanters. Our greater trochanters are now in profile. And that's exactly what we're talking about here. We want to make sure that we do not have a rotated pelvis. We want to make sure that our lower vertical column is centered, and we want proper rotation of the femoral proximal femora so that the necks are in their full extent without superimposition. The greater trochanters are in profile. The lesser trochanters, if seen, are on the medial border of the femora. On the AP oblique projection modified Cleves method, there's a bilateral frog leg position. The patient is supine. We're going to still center the mid-sagittal plane of the body to the midline of the image receptor. Want to make sure that the elbows and the hands are in the upper chest, and we're going to check the ASIS to tabletop distance as always to ensure the pelvis is not rotated. In step 1, we're going to flex the hips and the knees as much as possible and draw the feet up as much as possible to place the femora in a nearly vertical position. We're going to adjust the X-ray tube and the image receptor at this point. In step 2, we're going to center the image receptor 1 inch superior to the pubic symphysis. And at step 3, we're going to abduct the thighs as much as possible and have the patient turn their feet inward with the feet sole to sole and center to feet to the midline. Now the abducting of the thighs should be 45 degrees from the vertical plane to place the long axis of the femoral necks parallel with the plane of the image receptor. On the central ray, we're going to have the beam perpendicular to the image receptor to the mid-sagittal plane at a level 1 inch superior to the pubic symphysis. On collimation, we're going to adjust to 14 by 17, and for smaller patients, collimate 1 inch beyond the skin shadow on the sides. For structures shown, we have a bilateral image that shows an AP oblique projection of the femoral heads, the necks, and the trochanteric areas on one radiograph for comparison. Now, this image is contraindicated for a patient who is suspected to have a fracture or any other pathologic disease. So with this, we have no rotation. The pelvis is demonstrated by the symmetric appearance. We want to see the acetabulum, the femoral head, the femoral neck. The lesser trochanter should be visualized on the medial side of the femur. The femoral neck should be shown without superimposition by the greater trochanter, and there should be excess abduction that causes the greater trochanter to obstruct the neck. The femoral axes extend from the hip bones at equal angles. On the AP hip, again, the AP oblique projection of the hip, modified Cleese method, unilateral frog leg, non-trauma, again is contraindicated for a patient suspected to have a fracture or other pathologic disease. Our patient again is supine. We're going to center the mid-sagittal plane of the body to the midline of the image receptor. We're going to flex the elbows and place the hands on the upper chest. We're going to check the ACES to tabletop distance on each side to ensure the pelvis is not rotated. We're going to adjust the body position to center the ACES of the affected side to the midline of the grid. Have the patient flex their hip and the knee of the affected side and draw the foot up to the opposite knee as much as possible. We want them to brace the sole of the foot against the opposite knee and abduct the thigh approximately 45 degrees. The patient may rotate slightly. So we're going to be perpendicular to the image receptor to enter the femoral neck. We're going to adjust the collimation to a 10 by 12, and we're going to get an AP oblique projection of the femoral head, the neck, and the trochanteric area. We want to make sure that we have no rotation of the pelvis, but we want to make sure we have a symmetric appearance. We want to see the acetabulum, the femoral head, and the neck. We want to see the lesser trochanter on the medial side of the femur. We're looking at the femoral neck without superimposition by the greater trochanter. We want excess abduction causes the greater trochanter to obstruct the neck. And the femoral axes extend from the hip bones at equal angles. On the AP projection of the hip, the patient is again supine. We want to verify that ACES to tabletop distance on each side to ensure the pelvis is not rotated. Place the arms in a comfortable position, and we want to rotate the legs, the lower leg and the foot, 15 to 20 degrees again to place the femoral neck parallel with the plane of the image receptor. We're going to position perpendicular to the femoral neck, which is going to place the central ray 2.5 inches distal on a line drawn perpendicular to the midpoint between the ACES and the pubic symphysis. We're going to adjust our image receptor size to a 10 by 12. And we're going to get the head, the neck, the trochanters, and approximately 1/3 of the body of the femur. The thing is that this is we're going to make sure that many times that this AP projection is often obtained many times, not just for the down to the 10 by 12, but actually open to the 14 by 17 to get the entire pelvis. And so this could be a possible progress study. So just taking a look at the ideas that we're talking about, the midline between the ACES and the superior border of the pubic symphysis, and then drawing the line between the two, and then drawing a line 2.5 inches distal to that to get to the femoral neck, which is a shortcut of saying going about 2 inches medially from the greater trochanter. On this AP projection of the hip, we're going to be looking at the lower 1/3, looking at the 1/3 of the femur. We're looking at the femoral head penetrated and seen through the acetabulum. Leaving at the entire long axis of the femoral neck not foreshortened. We can see the greater trochanter in profile. The lesser trochanter is not usually projected beyond the medial border. Any orthopedic device should be seen in its entirety. On the lateral projection, which is called the Lowenstein method, that's the medial to lateral. From the supine position, we're going to rotate the patient slightly toward the affected side from an oblique projection. The degree of obliquity depends upon how much the patient can abduct the leg. So we're going to adjust the body and center the affected hip to the midline of the grid. We're going to ask the patient to flex the affected knee and draw the thigh up to position at a nearly right angle to the hip bone. We're going to keep the body of the affected femur parallel to the table. We're going to extend the opposite limb and support at the hip level and under the knee, and rotate the pelvis no more than necessary to accommodate flexion of the thigh and avoid superimposition at the affected side. We want to be perpendicular through the hip joint, midway between the ACES and the pubic symphysis. We're going to adjust our central weight to a 10 by 12, and we're going to get a lateral projection this time of the hip, including the acetabulum, the proximal end of the femur, and relationship of the femoral head to the acetabulum. Again, this is contraindicated for a patient that has a fracture or another pathologic disease. So this is a lateral projection of the hip. We're looking at the hip center to the radiograph. The hip joint, the acetabulum, and the femoral head is visualized. The femoral neck is overlapped by the greater trochanter. This is an axial lateral projection, Danielus-Miller method, the cross-table lateral hip. Now the patient is supine. We may have to build up the pelvis. We're going to flex the knee and the hip of the unaffected side to elevate the thigh in a vertical position. So that's the unaffected side is up. On the other hand, the affected side is going to be the one that's down, and we're going to grasp the heel and immediately rotate the affected side 15 to 20 degrees only if it's not contraindicated. The position of the image receptor is that we want to place the image receptor in a vertical position with the upper border and the soft tissue crease above the iliac crest, which is approximately 45 degrees in relation to the lower leg. We want to angle the image receptor away from the body until it is exactly parallel with the long axis of the femoral neck, and we want to support the image receptor. We're going to center perpendicular to the long axis of the femoral neck, and so it's going to enter the groin area. We're going to adjust the beam to its 10 by 12, and we're going to see the acetabulum, the head, the neck, and the trochanters of the femur. And here's an image just showing that we're going to be centering to the groin area. We're going to have the unaffected leg up, the affected side is going to be down, and we're going to center perpendicular to the femoral neck. That image receptor should be at approximately 45-degree angle to the lower extremity, to the femur. On the Danielus-Miller method, we're going to have the hip with the acetabulum. We're going to see the femoral neck without superimposition from the greater trochanter, a small amount of the lesser trochanters on the posterior surface of the femur, a small amount of the greater trochanters on the anterior and posterior surfaces of the proximal femur when the femur is properly inverted. The ischial tuberosity is below the femoral head and the neck, and we're going to see any orthopedic device in its entirety. Another option is a modified axial lateral projection Clements-Nakayama modification. This projection is performed when a patient has a bilateral hip fractures, bilateral hip arthroplasty, or limited movement of the unaffected leg. The patient is still supine, but for this position, we're not going to rotate the lower leg internally. Instead, it's going to remain neutral or slightly externally rotated position. We're to support the image receptor so its lower margin is just below the patient, and we're going to position the grid so that the grid lines run parallel with the floor. We want to adjust the IR parallel to the axis of the femoral neck and tilt its back 15 degrees because we're going to direct our central ray 15 degrees posteriorly. So we're going to want to make sure that we have our X-ray tube, our central ray is perpendicular to the image receptor. We also want to have the central ray aligned perpendicular to the femoral neck. We're going to adjust our collimation to a 10 by 12, and we're going to see the acetabulum and the proximal femur, including the head and the neck and the trochanters in lateral profile. And so what we're looking at here is that we're going to, again, have our central ray directed perpendicular to the femoral neck. We want to, again, have our looking at our direction of our central ray is going to be 15 degrees posteriorly. So we want to see the hip with the acetabulum. We want to see the femoral head, the neck, and the trochanters, and any orthopedic device in its entirety. The acetabulum includes two projections of each side, and that's called the AP oblique projection Judet method. The purpose is to demonstrate the entire acetabulum as well as the iliopubic and ilioischial columns of the affected side. In this example, our affected side is the right side in this example. So it's the right side. We're looking at two views, and we're going to place our patient on a 45-degree sponge. On the internal oblique position, which is the affected side up, we're going to align the body and the center of the hip being examined to the middle of the image receptor. We're going to enter 2 inches inferior to the ACES of the affected side, and we're going to adjust our collimation to a 10 by 12. What we're trying to focus on to see is the iliopubic column and the posterior rim of the acetabulum. On the external oblique, which is affected side down, we're going to be focusing now on the opposite side. We'll be looking at that 45-degree oblique again, but we're going to enter to the pubic symphysis this time. We're going to still collimate down to a 10 by 12, and we're going to focus on the ilioischial column and the anterior rim of the acetabulum. And so these images showing the internal, showing the iliopubic column and the posterior rim of the acetabulum, and on the external or the RPO showing the ilioischial column with the anterior rim of the acetabulum being visualized. The anterior pelvic bones, we've got the AP axial outlet projection called the Taylor method. Our patient is supine. We're going to center the mid-sagittal plane of the patient's body to the midline, adjust the pelvis so that it is not rotated. The ACES should be equidistant from the table. We want to flex the knees with the support. It's not shown here in the picture, but we should flex the knees with a support. We want to center the midline to a point 2 inches inferior to the superior border of the pubic symphysis. For males, we're going to direct the central ray 20 to 35 degrees cephalad. For females, we're going to direct the central ray 30 to 45 degrees. So if you just go halfway in the middle between the two, we just go with 35. So we're going to adjust the collimation to 14 by 17. We're going to collimate 1 inch beyond the skin shadow on the sides for smaller patients. And we're to see the superior and inferior rami without the foreshortening, as that you would normally see with an AP or PA projection. And so the purpose is to see the anterior pelvic bones. On this image, we can see that we've got the pubic and the ischial bones are magnified, with the pubic bones being superimposed over the sacrum and the coccyx. We've got symmetric obturator foramina and the pubic and the ischial rami near the center of the radiograph. So taking a look at this image, we have the superior pubic ramus, the inferior pubic ramus, and the ischial ramus that are all visualized bilaterally. The last projection to take a look at is on the anterior pelvic bones. Is the superior inferior axial inlet projection, Bridgman method. This is which for the patient is supine. We're centered to mid-sagittal plane of the patient's body to the midline and adjust the pelvis so it is not rotated. The ACES should be equidistant from the tabletop. We want to center the image receptor at the level of the greater trochanters, which of course is at the pubic symphysis. We're going to, the central ray is going to be directed 40 degrees caudate, entering midline at the level of the ACES. We're going to collimate to a 14 by 17, and as for always, we're going to smaller patients, we're going to collimate 1 inch beyond the skin shadows, and we're going to see an AP axial projection of the pelvic ring or inlet in its entirety. In this image, we're taking a look at the inlet. So we're taking a look at that brim, otherwise called, or the superior aperture, but that's what the goal is. And we're going to look for any fractures along that area. We want the symmetric pubes and the ischial spines, and we want the hip joints to be visualized as well. This concludes our lesson on the pelvis and the hip.